Chapter 18 Interprofessional Education. Interprofessional education, if adopted, can contribute to better delivery of healthcare. A move to IPE. Integrated teaching, as described in Chapter 710, is concerned with bringing together the disciplines within medicine. Interprofessional education occurs when two or more different professions learn with, from, and about each other. Although its implementation is not easy, IPE now features to some extent in many curricula and is mandated or recommended by a number of accrediting bodies. There are good reasons for this. If we expect a doctor on qualification to practice effectively as a member of a team and to have the required team and communication skills and an understanding and respect for other healthcare professionals, we need to reflect this in the curriculum and the educational strategies adopted. In medical practice today, no one profession can respond adequately to the range of problems presented by patients. It is essential that doctors have the necessary teamwork skills and understanding of different roles if they are to work alongside nurses, pharmacists, physiotherapists, health visitors, and other members of the healthcare team. The education of doctors has been largely conducted in a silo with little consideration given to the other professions and almost no collaboration with regard to joint educational programs. IPE enables the knowledge and skills necessary for collaborative working to be learned and can result in an improvement in the delivery of healthcare. The adoption of IPE has been encouraged by the move to outcome-based education as described in Section 2 of this book and the need for a more authentic curriculum as described in Chapter 12. IPE is now being adopted across the continuum of education from the early years of the medical school through postgraduate training to continuing professional development. Principles of interprofessional learning. The Center for the Advancement of Interprofessional Education in the UK developed several principles to guide the provision, commissioning, and development of interprofessional education. The vision is that interprofessional education works to improve the quality of care, focuses on the needs of service users and carers, involves service users and carers, encourages professions to learn with, from, and about each other, respects the integrity and contribution of each profession, enhances practice within the professions, increases professional satisfaction, continuum of interprofessional education. Interprofessional education can be described along a continuum of 11 stages from isolation, where healthcare professionals are taught separately from each other with no contact, to transprofessional education, where learning is based in practice. The steps are similar to the steps described in the integration ladder in Chapter 17. A decision should be taken on whether the school wishes to be on the IPE ladder. This should be higher than the first two rungs, and there should be some recognition of other professions in the curriculum. With time, the school may progress up the ladder. Implementation in practice. Implementation of IPE is not easy, and there are problems with regard to the timetable, location, and issues relating to the curriculum. With imagination, consideration, and collaboration, these can usually be overcome. The possibility of success or failure can be captured with the equation noted in Chapter 6 in relation to collaboration and applied to the context of IPE. IPE equals vision times the implementation strategy negative perceptions of the approach. Success is more likely where there is a well thought out and shared vision for what is to be achieved, an appropriate implementation strategy, and a plan to counteract a negative mindset. A vision for IPE. For IPE to be successful, we require a clear, agreed vision with achievable goals. Interprofessional education should have a vision that is imaginable, flexible, feasible, desirable, focused, and communicable. Course organizers, teachers in the different professions, and students need to have a common sense of purpose and a clear understanding of the rationale for the IPE and in their context what constitutes IPE. An implementation strategy. Methods used to implement interprofessional education in practice, as described by Barr, include action-based learning, for example, problem-based learning and task-based learning, exchange-based learning, for example, debates, case studies, shared lectures, and e-learning, observation-based learning, for example, joint visits to a patient by students from different professions, shadowing another profession and work-related practice placements, simulation-based learning, For example, role play, games, skills laboratory, and a simulated ward. The use of portfolios for learning and assessment. Resource materials may be developed that incorporate interprofessional practice. We worked with a multi-professional team from Africa to develop a training handbook for use by members of the healthcare team. The handbook was based on the common clinical problems encountered by healthcare professionals in their daily work, e.g., a patient with diarrhea. A general account of the management of the problem was provided in the top half of each page. In three columns on the lower half of the page, there were descriptions of the roles of the doctor, the nurse, and the health officer. The team members mastered the skills relating to their own roles, while gaining an understanding of the roles of other members of the healthcare team. How interprofessional education is implemented is important and may determine the success of the approach. In PBL, multi-professional groups may succeed or fail depending on the nature of the presenting problem, the briefing of the group, the facilitation by the tutor, and the debriefing. PBL worked effectively in our experience with a group of trainee midwives and medical students when the task facing the group required both the practical experience of the trainee midwives and the theoretical understanding of the medical students. The result was a positive shift in attitude of medical students towards midwives and vice versa. Other reported experiences of multi-professional groups where the task was less well defined and did not require the experience of the different professions have been less successful. In implementing IPE, there needs to be a clear statement of the expected learning outcomes for the curriculum and how the IPE contributes to achievement of the learning outcomes. Tackling a negative mindset. Any negative mindset of both staff and students must be tackled. The potential barriers to IPE need to be addressed at a leadership level. Views that must be rebutted and which contribute to an image problem for IPE include academic elitism, that IPE destroys individual characteristics, that there is a potential loss of professional identity, that personality conflicts are common, that IPE is not considered worth the effort, and that the logistics are too difficult.